Hi, good afternoon, everybody. We are coming to the end of tiring day, but very nice meeting. At the end of the day, we will discuss about heavy, serious cases of DILI resulting in acute liver failure. And for this session, my name is Zeki Karasu. We will co-chair together with Dr. Rebecca Jones, and our first speaker will be Gökhan Kabacem. I would like to invite Gökhan. Please, Gökhan.
Thank you, Professor Karasu. Let me share my screen. Okay, I hope you can hear me.
Yes.
Yeah, okay. First of all, I would like to thank to the organizing committee and Professor Günşar for the organization and the kind invitation, and wish all the audience healthy and safe day. So my topic here is mushroom poisoning and acute liver failure. I have nothing to disclose. So these two mushrooms are commonly mixed in Turkey. This is the well-known dead cap, the Amanita phalloides, and this is the ram mushroom, which is popular in the central Anatolia region. And today our topic will be on around this subject. So there are very widely seen natural mushrooms. Some of them are very delicious, as you know, as you may know, and some of them are looking very similar, but they can be dangerous. So our case today, actually not a case, a whole family of 4 people have attended to our clinic, and the main case that I want to mention here was a 21 years old male, and they ate altogether a mushroom dish in a family dinner together with his father, mother, and brother. And 12 hours later, nausea, vomiting, and diarrhea made them to go to the emergency room altogether. And the doctor over there was familiar, of course, with the situation, and he immediately performed gastric lavage, IV fluids, charcoal, and penicillin G infusion. But the next day of their hospitalization, they had an LFT surge, and they were referred to a local tertiary hospital. But unfortunately, later that day, their mother, who was 55 years of age, died very rapidly. But the other members, the father, 57 years of age, the younger brother, 18 years of age, they had the plasmapheresis plus N-acetylcysteine, silibinin infusions, and they were able to discharge in the 7th day of their presentation. But our patient here was on the 5th day of their eating this mushroom. He was unresponsive to plasmapheresis with hepatic encephalopathy, and he was referred to a liver transplant center. You can see here the liver transplant, our liver transplant center. These are the days of the presentation. Before the plasmapheresis, in the 2nd day, the AST was 1600, ALT 3600, bilirubin 8, and PT was 80. After 2 sessions of plasmapheresis, as you can see here, he had grade 2 encephalopathy. AST and ALT came down, but bilirubin was stable. That's why they thought that together with the encephalopathy, the patient was unresponsive. But as soon as he arrived at our clinics, we decided to go for 2 or 3 more sessions of plasmapheresis. And at the end of the plasmapheresis, in the 6th day, you can see the AST was 38, ALT 159, 56, bilirubin 5, and prothrombin time decrease. And he was discharged in 9th day in stable condition. Actually, this history brings to my mind a sad family history, so to speak. This part of Anatolia is, this is the Ilgaz mountain, where my family, my grandparents are from. There are various rivers all around and a moist place. And my grandparents was once eating did eat this bad mushroom, the Amanita phalloides, and they were just about to die in a few days, but fortunately they had recovered. So what about the problem? The mushrooms are commonly found and consumed. They are delicious, actually. Amanita, death cap is the other name, is the reason in 90% of the toxicity cases. They are easily mixed with each other. They are commonly found, especially in autumn and spring, the moist days of the year. In Turkey, around 1,000 cases per year are seen. Sometimes some kind of endemic mushroom toxicities appear in some months of the year, according to the Ministry of Health data. In the Western world, it's not a big problem. It's around, in the western part of the Europe and North America, around 50 to 100 cases per year are seen. And the other problem, because the mushroom is not always eaten by only one single individual, there are familial clustering of the cases. This can be a problem for the healthcare system. This can cause a problem to find a place in the ICU, or sometimes difficult to find a liver donor if you will need to do a live donor liver transplantation. So the main ingredient, the toxic protein enzyme, is alpha, and the other minor ones are beta and gamma amanitin inside of this mushroom. And when it enters the cell, it causes immediate apoptosis, and it blocks the protein synthesis. It causes reactive oxygen species burst, and when it enters the enterohepatic circulation after the digestion process, hepatocytes and renal cells take it in. RNA polymerase II is inhibited. As I told you, protein synthesis stops, and the lethal dose of this alpha-amanitin is as low as 1 mushroom. So what do we see in clinics? 3 clinical phases are very well described. Asymptomatic lag period of 5 to 24 hours, median is 12 hours. Gastrointestinal phase is comprised of the nausea, vomiting, severe watery diarrhea, which is seen in 12 to 24 hours. If it's earlier than this, it could be related with worse prognosis. We know that. And just after this gastrointestinal phase, there is a pseudo-recovery phase, so to speak, when the patient is better than the presentation. And later, in 2 or 3 days' time, hepatorenal phase comes with the elevation of aminotransferases, coagulopathy, jaundice, hepatic encephalopathy, acute hepatic and renal failure. And during this time, we can see both acute liver injury and with probably encephalopathy, coagulopathy, with very high transaminases, but plus lactic acidosis and multi-organ dysfunction makes it to acute liver failure. So management. What do we do for the management of these patients? The most important thing, one of the most important things is the physician should be aware of the possibility of seeing the mushroom in that part of the world in that particular time of the year. And when we see the patients with typical symptoms, best in first hour of presentation or consumption of that mushroom, oral decontamination should start for the prevention of the absorption of this toxin. We can use active charcoal, we can use, gastric lavage, which are best working in the earlier phases. But after the absorption starts, we should try to eliminate the absorbed toxins. How do we do that? IV rehydration is important because the dehydration is very common in these patients, and the lactic acidosis is rapidly developed and yielding to acute kidney injury. The diuresis can be helpful to increase the renal clearance, especially in the first 2 days of presentation. 100 to 200 ml per hour of IV fluid and electrolyte replacement is recommended. Biliary drainage to block the enterohepatic circulation in various ways could be used, although not so common. The more popular ways are extracorporeal elimination, with plasmapheresis, with other supportive measures. The effectivity of the plasmapheresis decrease the mortality to less than 10%. We know that. It's also more effective in the late presented patients. Plasma exchange is good for bilirubin and coagulopathy, but if we combine it with double plasma molecule absorption system, the toxins are better filtrated as well. Mars and Prometheus, I will have a few words on them. This is the Mars system, popular. There is poor data in mushroom poisoning with the Mars system. It is safe, but it doesn't significantly affect the mortality, and liver transplant need is not altered with use of Mars. But the Prometheus here seems to be more effective. You can see with the treatment in the days past, in the study, the prothrombin index increases and nearly normalizes with the use of Prometheus, and also the factor 5 level is increasing by the use of Prometheus. The bilirubin levels also increase more rapidly in the patients in the control group, but the Prometheus group, the rise of bilirubin is in a lower angle. And the toxin level before and after the Prometheus, you can see that there's a steep decline, and Prometheus clears the toxins. So this can be a nice bridge to transplantation or sometimes even to recovery if you can reach to this device. So in the management before the last one, I I will say a few words on the potential antidotes, of course. These are important. Benzylpenicillin is the most commonly used medication. It blocks the organic anion transport protein, and the hepatocellular uptake of this toxin is blocked by this way. In the monotreatment with benzylpenicillin without other supportive measures, the mortality is even higher. So we should add something. We will discuss later on. Dosage is very high, 1 million units per kilogram per day. As you know, the allergy can be a problem. And in some cases with the renal problems, it can be even more other problems. The N-acetylcysteine is the other detoxifying agent, so to speak. The mortality rate, including liver transplant, is around 11% with the use of N-acetylcysteine. When excluding the severe cases with liver transplant, the mortality by using the N-acetylcysteine is 7.9 in this meta-analysis. Liver transplant rate among the patients using N-acetylcysteine was 4.3%. LFT and INR peak was 3 to 4 days and normalization in 7 days. But of course, we know that N-acetylcysteine can have some side effects: adrenal failure, GI bleeding, anaphylactic reaction, relatively common, up to 5%. And also we know that if we initiate a NOC early, mortality will be lower. In the first day, if we initiate the N-acetylcysteine, mortality will be 6.3%, but if later, 23%. It's safe and reasonable. This is the milk thistle, famous, you know. The cynamarine or silibinin is an extract of this, and monotherapy is better than combination with the penicillin G in a study. It inhibits the hepatocellular uptake of the amatoxin and interrupt the enterohepatic circulation as well. It reduces the amatoxin intracellular concentration by these two mechanisms, and it decreases the mortality to less than 10%. Polymyxin B is another agent which binds to the same interface of alpha-amanitin in the RNA polymerase II protein, and thus prevents the toxin from binding to it. In vivo studies, animal studies are effective. It can be applied as a novel pharmacological approach, but as all the other treatment options, large-scale clinical studies are lacking. So maybe the most important part of this presentation is the prognostic criteria. So we give these supportive measures. We treat most of the patients, but some of the more severe patients will face with mortality in around 10 to 20% of patients. According to the papers from Turkey, it's around 2.5 to 14%. I think this slight decrease is not significant. So how do we select the patients to present to go to transplantation? Of course, most important criteria is King's College, but it has some limitations, as we will talk about in a minute. We know the INR or more than 6.5, or PT more than 100 seconds, or 3 out of 5 of following: the age, jaundice more than 7 days before the hepatic encephalopathy. And I should stop here because most of the patients even die in this time period if they will present and they will go in a severe fashion. So we won't have to the time necessary to evaluate about this. PT more than 50s, INR more than 3.5, bilirubin more than 17.5 milligrams, non-A, non-B hepatitis, no DILI, These two are valid for nearly all patients. Age, okay, it's controversial. So the only criteria out of King's College seems to be this bilirubin and INR criteria. And there are some other criteria more specifically studied on the mushroom intoxication patients. For example, the Bonassini study says that peak AST more than 4,000, then transfer the patient to liver transplant center. Females and elderly patients, as in our sample case, have a worse prognosis than male and young patients. So Kim has a very nice study on this as well. Presence of total bilirubin more than 5 or APTT more than 50 on day 3 was prognostic of impending in-hospital death. So you can see here it's APTT, not PT. So this has nothing to do with the liver synthetic capacity, but it's more related with the multi-organ deficiency seen in the severe patients with acute liver failure. So you can see here in their chart that the APTT is higher in the non-survival group compared to survival group. Bilirubin is high, but when they do the multivariate analysis, these are more important. The bilirubin is higher in the non-survival group, as you can see here. So these two numbers can be important. So Ganzert has done the most crowded population cohort study and retrospective study. So they tell that we should list the patient for transplantation regardless of hepatic encephalopathy if the prothrombin index is less than 25 or creatinine more than 108.6 micromole per liter on 3rd day of ingestion. So they have done this algorithm in later than 10 days. For example, there will be probably no need for liver transplant. Either they will die or they will have the liver transplant if they have the necessary criteria. Escudi's criteria is also supported with some other groups as well. Liver transplant if onset of diarrhea less than 8 hours of consumption of the mushroom. This is because in their cohort of around 30 patients, all of them were around 78% of them were fatal if the diarrhea is seen in the early as an early onset after the consumption. Also, we should list the patients regardless of encephalopathy or creatinine level on the contrary to Ganzert's criteria, but the INR more than 6 is important, or decrease of prothrombin index below 10% of normal in 4 days is important. You can see here in the fatal intoxication, prothrombin never comes up, but in non-fatal intoxication, it comes down and turns back to normal in around a week or something. The time interval between the presence of different criteria for transplantation and death or transplantation is seen in Escudi's study here. As I told you, King's College criteria can be a little bit late to find out the transplant necessity. Clichés, of course, is better because you look for the factor 5 level, but it's not widely available in many centers, so I didn't mention it. So we proceed to the liver transplantation, which is indicated, but it's uncertain due to lack of high level of evidence. If the patient has encephalopathy, higher MELD or PELD, INR, bilirubin, ammonium levels, or lower platelet counts, they were found to be related to worse clinical outcome after mushroom intoxication. Liver can deteriorate fast, so we should follow the patient in a liver transplant center if he or she has acute liver failure. DLT gives similar results with DDLT in experienced centers, although, as I mentioned ago, finding a suitable donor from the family can be an issue after the family dinners, making all the family members sick. And this is in line with our Turkish study on ELF patients, which will be mentioned later by Dr. Murat. Auxiliary liver transplant is another option in selected patients if we think that the native liver can regenerate. If the patient is a child, maybe we can prefer this, but it's it can be done in highly selected patients in centers with high level of experience. So what are the take-home messages? Mushroom intoxication is rare, but the important reason of ALF. Amanita is the reason in most of the cases. GI symptoms are followed by hepatorenal phase. It can be mortal in around 10 to 20% of the cases. Prevention of absorption, elimination of the toxin, antidote therapies are effective in most of the cases. 3 to 5 days of waiting is important for decision making to proceed for the liver transplant, as far as I think. Liver transplant is the best option in severe cases with delayed recovery from coagulopathy, nephropathy, encephalopathy. But we should keep in mind that even Clichy 3/3 or King's College 3/5 or more criteria carrying patients can spontaneously or recover with supportive measures. 83% of the mortality will be in 9 days' time. And also the increasing public awareness, as done in late 2008 or something in Turkey, works to inform the people about the toxicities. So mushrooms are delicious, they look good, but they can be harmful. They are not the best, they are not our homes or friendly always. Thank you for your attention.
Thank you very much for that great tour of how to manage acute mushroom poisoning. I'm not sure I'm ever going to eat a mushroom again in my life. We're going to take questions at the end of this session, if that's okay. So hi everybody, my name is Rebecca Jones, I work in Leeds, and thanks for asking me to chair this session. I'm going to introduce our next speaker, who is Adrian Rubin from London. He's going to talk on the management of drug-induced acute liver failure. Thank you very much.
Ah, okay, I'm unmuted. Is my screen visible? Is my screen visible to people?
So Adrian, we can see your screen, but what we can see is your slides and then your slide set as well. That's great.
But how can I get to my... There we go.
Okay.
I have to get all your faces out of my way. Okay, shall I start?
Go ahead. Thank you.
All right, what a pleasure. I was very pleased that Guru gave me this topic, because although I've spent a long while looking at drug-induced liver disease and a long while involved with liver transplant and liver failure, putting them together in this way was actually something of a challenge. And I'm glad to have that. I must give thanks to various friends, mostly in America, you see below. Also, Guru gave me some good advice. And if anybody, let me just see if this will work. Yes, I give you there my email address. If anybody would like a copy of the lecture or any of the articles that I've quoted, I'd be very, very pleased to send them. So let's start with some definitions. Actually, before doing that, I want to warn you that I'm not going to discuss the management of acute liver failure itself, but rather how we approach the patient with potential acute liver failure or actual acute liver failure, which is drug-induced. So the rather restricted view. So let's start off with some definitions. According to Todd Stravitz and Will Lee in their Lancet, excellent Lancet review, they say that fulminant hepatic failure is an obsolete term. And I see that people are using acute liver failure. I actually think that fulminant hepatic failure is much more informative. If you look it up in the OED, fulminant means acute and sudden and severe, whereas acute really doesn't imply that same degree of urgency. At any rate, it's damage to hepatocytes, which leads to two main features. One is coagulopathy, and defined as an INR greater than 1.5, and the other is hepatic encephalopathy, which may range anywhere from mild encephalopathy grade 1 all the way to deep coma. And this is defined in the absence of chronic liver disease, which is a vague exclusion, but what is really meant by that is cirrhosis. But there are exceptions, and you see them here, where underlying cirrhosis may be, as it were, quiescent, and the flare of the disease actually presents in an acute way, as if there was no underlying disease at all. The time course originally was defined as less than 8 weeks, based on a 1970s study of halothane hepatitis, another drug-induced liver injury, where, knowing the date of exposure, the investigators could define exactly the last week or the last moment that such an event might occur. Actually, this was never published as a peer-reviewed paper, but was part of a book chapter. Kind of interesting how this has become canonized. And then it was extended up to 26 weeks. Now, at some stage, the King's people were dividing the time frames into hyperacute, acute, and subacute, and these are no longer really thought to be useful. But the hyperacute form is really rather distinct, and it has a distinct pattern in terms of sudden onsets, high level of cerebral edema, and by and large a pretty good outcome. Jaundice isn't part of the definition, but of course is often present. And it's important not to confuse acute liver failure with acute on chronic liver failure. Of course, there you have an underlying cirrhosis with acute decompensation, but with a lot of extra hepatic manifestations. Now, as we heard in the previous talk, acute liver injury without hepatic encephalopathy is another term, ALI, that we're using. Etiology of ALF, many causes and worldwide geographical variation. Here, for example, are the causes of acute liver failure in the US. This is a result of a prospective study of now nearly 2,600 individuals. The study is now closed, and you see that almost half of them were due to paracetamol, which the Americans like to call APAP. Well, I'll explain that in a moment. 11% were other drugs, and 12% the cause was indeterminate. On later causality analysis, we were able to reduce that 12% down to about 5%, and the majority ended up as being due to paracetamol acetaminophen. Here are the proportions that we see worldwide. Now, the US and UK are similar in their proportions of paracetamol and other drugs, shown with the pink and the gray. And if you look in Germany, paracetamol and other drugs are present. But if you go to other countries in the world, paracetamol as a cause of acute liver failure actually disappears. Now, drug-induced liver injury, or DILI, has also been called drug-induced liver disease, drug hepatotoxicity, which was the term that Hy Zimmerman used. I actually introduced the term ZILI for xenobiotic-induced liver injury, because in fact there's a rapid increasing use of over-the-counter drugs, complementary alternative medicines, dietary supplements, which I used to abbreviate as HDS, but I learned at this conference that HILI and SILI are terms that are used, and other recreational substances, including weight loss and bodybuilding. The injury here is not just hepatocytes, but also parenchymal liver cells, endothelial cells, stellate cells, and so on, which give rise to the varied histologic appearance and the varied clinical appearance. On the whole, it's divided into three major classes: hepatocellular, which constitutes about 2/3 of the cases, rising in aminotransferases; cholestatic, with a rise in alkaline phosphatase and usually bilirubin as well, and a mixed picture. And the ratio and the definition is from this relative increase in aminotransferases compared to the upper limits of normal and alkaline phosphatase as a ratio. So, for example, an R above 5 indicates hepatocellular, an R below 3 indicates cholestatic, and the mixture in between. The presentation, of course, as we learned earlier, anywhere from asymptomatic biochemical abnormalities to full-blown ALF. And we heard earlier about liver histopathology. It may be suggestive of DILI, but is rarely pathognomonic. However, with ALF, it may all be obscured by extensive necrosis, and liver biopsy may actually not be very informative at all. Now, like ALF itself, DILI has many causes and a wide geographical distribution. Now, here are results of not ALF, but just non-acetaminophen induced DILI, and you can see that in the US, half the cases are due to antibiotics, and in India, this rises to 58%, purely anti-tuberculous treatment. If we look down at other drugs, these are more prominent in other parts of the world: Sweden, Spain, and Japan. And the intriguing one here, for example, in the Far East, where here in Korea, 3/4 of the cases of DILI are actually due to herbal local remedies and so forth. When we looked about 10 years ago in the acute liver failure study group at 133 of the patients then who were identified as having non-acetaminophen DILI, you can see that 50% are due to antibiotics. Strange to relate that there were none due to amoxicillin clavulanic acid, and I just don't understand that. At any rate, the rest were anticonvulsants, non-steroidals, and in those days, the herbal and complementary medicines were only 11%, but that was before the recent rise in their use. Here are different results from the US and the UK. On the left, you can see that acetaminophen paracetamol is consistently, and although the graph ends in 2013, actually continues to this day, represents 50% of the cases that were recruited to the acute liver failure study. Interesting, if you look back in the very early report, there were only 31%, and in fact in America, they considered that like syphilis, paracetamol overdose was a British English disease. In actual fact, they were missing the fact that that Americans were overdosing on paracetamol as well. If we now turn to Britain, we have an interesting picture. There was a rise in paracetamol associated admission to the liver intensive therapy unit at King's up until the late 1990s, and the introduction then of paracetamol sales restriction led to a prompt and really satisfying fall in that disease. Now, just to the bottom left, just for fun, I've showed you the derivation of 3 terms that are used for acetaminophen. Paracetamol in the UK, I mentioned APAP in the US, and Tylenol is the popular brand name, and you can see the derivation of the names itself. One other fact I'd like to point out to you is there are 2 very wonderful histories, both of paracetamol and of acute liver failure, have been published by Will Lee and also Will Bernal and late Roger Williamson here, and I heartily recommend these most entertaining and informative articles. Now, as we heard earlier in the course, we divided drug-induced liver injury into the direct dose-independent disease that could affect anybody who took a large enough dose of the particular substance, and contrasted that with so-called idiosyncratic, which was only in susceptible individuals and was not thought to be dose dependent and so on. But more recently, we've learned that there is another form of drug-induced liver injury, so-called indirect, which happens to be of intermediate frequency between the other 2, and is delayed after many months of taking the substances involved, whereas the direct are usually very rapid onset, as we've learned just now with mushroom poisoning. It's commonly thought that idiosyncratic is dose independent, but in fact, if you look at all the individual drugs that cause this syndrome, they're almost always taken in a dose of more than 100 milligrams daily, but it's not dose related in any other sense. The other point I'd like to make here is that this indirect are due to indirect actions on the liver or the immune system, and the best example in a way is the immune reconstitution that occurs after a chemotherapy treatment in patients who have latent or quiescent hepatitis B leading to reactivation. And if we look back at the idiosyncratic cases, we have 3 forms: the metabolic, the immunoallergic, which has a strong class cross-reactivity, and the very interesting entity of autoimmune-like, where the disease mimics very strongly autoimmune hepatitis. So we take a compulsive approach to these patients with potential DILI ALF because we want to make sure the diagnosis is correct, and we have the etiology because these will influence our treatment and the outcome. So we take a compulsive history, and here a whole range of witnesses that we choose. One that is often overlooked, I find particularly useful because patients forget what drugs they've been prescribed, and that is to call the pharmacy and find out what has actually been prescribed within the last year. And here's a very nice, amusing article from University of North Carolina in Chapel Hill, senior author being Skip Hayashi, where he actually reports on the value of that sort of practice. We want a description of the acute presentation. Obviously, we want the medication history, including all of these complementary things, but we also want to know if the patient's taken sedatives or drugs containing sedatives, because this may influence their presentation and make their hepatic encephalopathy look worse, or actually, if it's not existent, look as if it's present. It's very valuable to look at the drugs themselves and their containers. The physical examination, obviously, we need accurate assessment of the degree of encephalopathy. We also want their blood oxygen level. We want to see if there's signs of previous liver disease and evidence of an immunoallergic reaction, which might help us identify DILI as the cause of their illness. Now, routine laboratory investigation should include differential eosinophilia, but also phosphate and lactate, pH and blood gases, because this is going to determine the severity of their acute liver failure. We always measure acetaminophen levels, although these may be transient and disappear within a few days. And recently, Leventhal and colleagues have published 2 years ago an article describing how more than 50% of patients who present with acetaminophen toxicity actually do not have it detectable in the blood. A urine tox screen is valuable to see if the patient has an addiction problem that might preclude them from transplantation. Include hepatitis E, which is masqueraded as DILI in a number of publications, and we're always on the lookout for Wilson disease, which again can mimic DILI, because that would be a disaster to miss it. And it's worth doing some herpes virus studies, as occult herpes virus again has been found in a number of cases that might have been thought to be due to DILI. Now, more advanced testing is shown here. It's all very well known to those of you who are involved in liver transplantation. What is very controversial, though, is whether to perform a biopsy, which invariably has to be done by the transjugular route. And if it's done, gives an opportunity to measure the pressure gradient and some venography. But I think it's only useful if we have a serious diagnostic difficulty, if the data are conflicting, or if the patient progression stalls. In other words, they don't get better, they don't get worse, and you're in two minds as to whether what their outcome is going to be. Will they need a liver transplant? A liver biopsy there may be helpful. And sometimes unexpected findings that you would never have imagined, that the patient has lymphoma infiltrating the liver. And as we said earlier, the histopathology is not pathognomonic unless, of course, you find a lymphoma, but also may be markedly obscured by extensive necrosis. Now, what about DILI-specific testing? Remember, DILI is a diagnosis of exclusion, utilizes only circumstantial evidence. And so there are a number of series of tests that we can do to try and narrow down the diagnosis. The laboratory results might be indicative. There's causality testing, which we heard about earlier from Marsha Morgan, so I will not describe the RUCAM. I would like to introduce to you the Liver Tox website if you haven't come across this. And there I'll tell you a little bit about some evolving assays for paracetamol toxicity and evolving dynamic tests of liver function that could be useful for prognosis. Now, here are the clinical presentation, of course, of acute liver failure according to the etiology, again from the acute liver failure study group. And you can see that if you compare paracetamol to the rest, it's quite strikingly different. Very, very high enzyme levels. And although hepatitis A has very high enzyme levels, the contrast is that paracetamol rarely presents with jaundice, whereas viral hepatitis usually does. The rest of the diagnoses are much of a muchness. They all look much the same, and it's very hard to distinguish. Interestingly, of course, paracetamol and hepatitis A have very good outlooks with spontaneous recovery, transplant-free recovery, and the rest are pretty grim. But when transplant is added to the mixer, you can see that it brings up the recovery of all of these low outputs, low result states. And this has led to an understanding that there are favorable etiologies of ALF and unfavorable ones. The favorable ones are paracetamol, hepatitis A, pregnancy associated, and ischemia, and paracetamol toxicity is clinically extremely similar to ischemia. Now, this is the Liver Tox website, and although the link below is very complicated, if you just search liver tox, you will reach it. This is a repository of well over 1,200 detailed descriptions of the manifestations of liver injury from all of these drugs and a certain proportion of herbal remedies as well. It's updated every month. This is the baby of Jay Hufnagel, and is actually a remarkable resource. Now, let's talk about some new ways of looking at toxicity. Paracetamol, we know, is metabolized to the toxic NAPK, and this binds with proteins via their cysteine residues and can actually be detected by HPLC in the serum. The threshold for toxicity is greater than 1 micromolar, correlates very well with AST. Unlike acetaminophen, it remains positive for 9 days, and it turns out that in 20% of indeterminate cases, it is positive, so these may represent occult paracetamol. Here's the early study by Tim DeVerne looking at the adducts in a whole range of cases. Here is known paracetamol toxicity compared to other causes of ALF, paracetamol ingestion without toxicity. But here, 20% of these indeterminate cases were found to have positive adducts. The next graph shows how the adducts last in the circulation much longer, here up to 10 days above 9 days above the toxic level. And unfortunately, the development of a bedside so-called dipstick assay or test strip assay, which has been going on for a number of years by Laura James and her colleagues in Arkansas, is still under development. And they've had a very difficult time with the FDA. Here is a comparison of the HPLC and the dipstick. And the reason it looks the wrong way around is because what you see on the test strip is a disappearance of a signal when there are increasing amounts of adduct in the circulation. Now, to make a prognostic assessment, there are many, many attempts to do that. The MELD score, which you can calculate from the Mayo Clinic app, the King College Hospital criteria, which were mentioned in the previous talk, have been around since 1989 when John O'Grady introduced them. There's an app there. Here are the variables. And one that we developed in the acute liver failure study group is a prognostic model for which an app is available. The variables are the degree of encephalopathy, favorable versus unfavorable etiology, which I've just explained, the INR, and whether vasopressors were necessary. And here is the appearance of the app. Unfortunately, it'll have non-international units. It'll be milligrams and so on. But on the other hand, it gives you a very, very easy, fast way, and the app is actually free. The other new development I want to tell you about are some dynamic tests. Here's the C13 methacetin breath test, a non-radioactive isotope. And in this study, it was compared to the MELD score, the King's College criteria, and the acute liver failure prognostic index. And here are the results, where the breath test is combined with the etiology or the breath test alone. And you can see that the areas under the curve are greatest for the prognostic index, but the breath test comes a very close second. Now, as far as specific treatments for acute liver failure are concerned, there are really only two that we're going to bother with. The first is the ALI and all types of ALI. And then secondly, we consider DILI, that is presenting as acute, as autoimmune hepatitis. So obviously the first thing is to stop the culprit agent as soon as possible. Transplant may be required, of course, and as I've shown you, it increases the survival tremendously. We caution against the use of steroids. On the other hand, if the DILI is a very strong mimic of autoimmune hepatitis, then steroids, a short course of those may be possible. We heard in detail about silibinin and penicillin. These results and these reviews should be published and enlarged, because so far one can consider the evidence somewhat anecdotal. Now, steroids in acute liver failure is a very controversial topic. In acute liver failure due to non-immune DILI or indeterminate ALF or advanced DILI that presents as autoimmune hepatitis, steroid use is ineffective and complicated and should be avoided. Now, DILI presenting as autoimmune hepatitis may actually mimic idiopathic ALI clinically and histologically. And if it's really that, then it should resolve on drug withdrawal, which is the first line of therapy. If there's any hint of fibrosis in such cases, then we're probably dealing not with AIH DILI, but with idiopathic AIH. If bona fide DILI AIH does not resolve quickly on drug withdrawal, then we should try steroids, and these should be effective and not relapse. And here is a decision tree for the therapy of DILI autoimmune hepatitis published by Al Shire a few years ago, and you can see that if there's relapse in any of these different patient groups, then you're actually dealing with bona fide idiopathic autoimmune hepatitis and not DILI. Some people say only try steroids in DILI, AIH, ALF if there's strong immune activation systemically, and in bona fide non-DILI autoimmune hepatitis, only use steroids if the hepatic encephalopathy grade is mild, as there's and there is speedy improvement. Otherwise, we must consider that this is a failure and refer the patient urgently for transplantation. Now, I know there's been a session on the immune checkpoint inhibitors, but I just wanted to make a point of where we stand with this form of DILI and ALF and death. And you can see that of the agents here, from a very large survey, there were only 8 deaths representing 0.04%. 2 of the 8 were with the PD-1 alone, and 5 of the 8 were with the high dose treatment, and only 1 with PD-L1. Unfortunately, these patients are usually cancer patients, and even if they do develop ALF, they will not be transplant candidates. I just have to say a word now about all these acronyms. We've got DILI, HILI, SILI, ZILI, and now CHILI. And I think in the words of Monty Python, and now for something completely different, these are all actually very silly. The mechanism of these drugs is obviously indirect hepatotoxicity due to an enhanced autoimmune state from ICI-induced cell activation. And as you heard earlier, it's graded in 4 levels, which recommend the use of immunosuppression depending upon the level. Now, as far as N-acetylcysteine is concerned, which we heard about in the previous talk, when a study was done in non-paracetamol ALF, only the mild to moderate encephalopathic patients responded, as you see here, compared to placebo. And when this study was repeated in children, in fact, there was no benefit at all. So it's certainly worth trying N-acetylcysteine. Anecdotally, it may actually help. It's probably only valuable if there's mild encephalopathy, but since it's a fairly safe drug, I think it's a reasonable approach. So how do we manage DILI acute liver failure? I haven't time to tell you how to manage acute liver failure. It's a separate talk. You obviously stop the causative agent as soon as possible. Intravenous NAC, useful paracetamol, DILI, although it's only the Cochrane library review suggested that the data that supports this is rather poor. Do we give intravenous NAC for early non-paracetamol DILI ALF? I would say so. And we will give DILI for bona fide DILI autoimmune hepatitis if it's mild and persists after stopping the offending drugs. The management of acute liver failure in any circumstances is proactive and it's key, but there are few prospective trials. Early referral to a transplant center, early institution of renal replacement therapy to lower blood ammonia, and we know that very high blood ammonias are related to cerebral edema, elective mechanical ventilation as the patient becomes more encephalopathic, hypertonic saline for the prevention of cerebral edema, but I don't know how prevalent it is to use hypothermia. Avoid plasma, which is not valuable in correcting the abnormal coagulation, and treat potential infections empirically if the patient is deteriorating. One last slide. I want to advertise the free monthly online seminars on DILI that are a product of the Hepatotoxicity Special Interest Group of the ASLD. And you can see that next month we have Lloyd DeLeve with a basic science talk. After that, Lily Dara again, and then ending up in this particular academic session with Harshed Devabavi giving a talk about DILI in Asia. And with that, I will finish and thank you. I can't hear you.
Sorry, I just forgot to open my microphone. Thank you, Dr. Ribbon. It was a great pleasure to listen to your wonderful lecture. I really enjoyed it. And despite all medical efforts and supportive measures, the chance of spontaneous recovery is poor, and liver transplantation sometimes the basic definitive treatment option for those patients. Particularly for cases reaching grade 3 or 4 encephalopathy, the spontaneous survival rate quite low. In countries with the scarcity of diseased organs, organ shortage is really a problem, and to overcome that problem, live donor liver transplantation will be an option. And now Dr. Murat Akyıldız will tell us about his experience about living donor liver transplantation in the case of acute liver failure. Please, Murat.
Yes. Hello. Can you see my slides?
Yes.
Okay. Hello, everybody. I'd like to thank the organizing committee for this wonderful meeting, and I hope this meeting is the beginning of the TASL and BASL collaboration and is going to continue with additional meetings and studies. And especially, I would like to thank the Professor Günşar and Guru. And it's a little hard to talk after Mr. Ruben and before Guru. I try to do best. Now my topic is living donor liver transplantation in drug-induced acute liver failure and Turkish experience. This is outline of my talk. First, I will talk about liver-related acute liver failure and literature and living donor liver transplantation for acute liver failure, and then living donor liver transplantation experience in Dili, and finally I will talk about Turkish experience. When we look at the Dili-related acute liver failure, there are two main groups, and paracetamol-induced and idiosyncratic Dili, and those are about over than 50% of the patients with acute liver failure in the Western countries. And as you can see from this slide, drug-induced liver injury combining both paracetamol-induced and idiosyncratic Dili, especially in the United States and in Europe, accounts over than 50%. On the other hand, viral causes are the primary leading factor for acute liver failure in Eastern countries and in our country. And the true incidence of idiosyncratic Dili-related acute liver failure is more difficult to determine due to under-reporting and under-recognition. In the United States, idiosyncratic Dili is believed to be responsible for 11% of all acute liver failure cases, and with the number of idiosyncratic Dili-related acute liver failure and deaths to be about 300 to 500 per year. There are some differences between paracetamol-induced acute liver failure and idiosyncratic Dili. Professor Ruben mentioned about it, and but prominently high-grade encephalopathy on initial presentation only occurs in 1/3 of the patients with idiosyncratic Dili, and spontaneous recovery is about 65% of in paracetamol group. On the other hand, in idiosyncratic group is about 25%, and the time from onset of jaundice of hepatic encephalopathy is longer, and jaundice is more prominent in patients with idiosyncratic Dili-related acute liver failure. Herein you can see the list of major causes of idiosyncratic drug. The common prescription medications implicated in idiosyncratic Dili are isoniazid, nitrofurantoin, trimethoprim sulfametoxazole, phenytoin, and whereas chem and dietary supplements are responsible for about 10% of idiosyncratic Dili-related acute liver failure cases. So this study was published in 2010 by Ruben from USA. It's a multi-center trial. There were 133 acute liver failure patients with DILI from 23 sites and over 1,000 patients reports in the USA. And you can see the outcome of the patients with DILI-related acute liver failure. There were no difference according to age, race, gender, drug class, and R value between spontaneous survival, transplanted or non-transplanted death group. But coma grade was higher in the transplanted and non-transplanted death group than spontaneous recovery group at the hospital admission. And transplant-free survival group has lower MAD score, lower bilirubin, INR, and creatinine levels, and there were no difference according to BMI and transaminase levels between the groups. So in the USA, idiosyncratic DILI accounts about 11 of all acute liver failure cases and is associated with a 3-week transplant-free survival about 27%. On the other hand, in China, the DILI-induced acute liver failure is about 44%, and spontaneous recovery is about only 23%. And the most commonly implicated agents leading to acute liver failure-related DILI in the USA are isoniazid, bactrim, nitrofurantoin, and HDS products. However, emergency liver transplantation offer an excellent survival benefit in those patients. And on the other hand, series from countries with limited access to transplantation also demonstrate a low rate or spontaneous survival rate. And so in those groups, the spontaneous survival rate is about 10%. So liver transplantation is the life-saving option in acute liver failure, and in the presence of limited cadaveric organ donation, living donor liver transplantation may solve this problem, especially in Eastern countries and in our country. However, the question should be asked, is living donor liver transplantation safe for donor in this emergency situation, and what about the recipient outcome? And this study was published in 2019, investigated living liver donor safety and recipient outcomes following living donor liver transplantation for acute liver failure. And outcomes of emergency living liver donation were comparable to that of elective donors, and emergency living donor liver transplantation is life-saving in selected patients with acute liver failure. The median donor evaluation was reported as 18 hours. There was no donor mortality, and in our country, in selected centers, it depends on the center experience. We can make it about 8 or 10 hours according to patient and patient family status. So the median donor age for elective liver transplantation was 29 years, whereas donor age for acute liver failure was a little younger, 23 years. And in the entire cohort, about 58 of the donors were female. And 5-year post-transplant patient and graft survival was about 65, and the survival in pediatric patients was a little high according to adults. And during the same time, the 5-year actual patient and graft survival is about 80% for patients who underwent elective living donor liver transplantation for chronic liver disease, and median follow-up was reported as 35 months in this trial. So when we look at the results of living donor liver transplantation for acute liver failure in the literature, the clinical condition of recipients and other published studies, the etiology has been shown to be an important prognostic factor in predicting transplant-free survival, and Mr. Ruben mentioned about it. The patients with unknown etiologies and drug-induced liver failure have worse outcomes compared with those with viral etiology. So, what about the results of living donor liver transplantation in idiosyncratic DILI-related acute liver failure? And this study reported from North India about living donor liver transplantation experience in DILI-induced acute liver failure as a single center experience. There were 18 patients and 15 of the patients were females, age were 34 years old, and causes of DILI in those patients were antituberculous medications or listat flutamide and complementary medications taken for hypothyroidism in 2 patients. And you can see from the table, the waiting before liver transplantation was only 1 day. And they compared the results of post-transplant survival of DILI-related acute liver failure and other groups, acute liver failure etiologic groups and chronic liver disease groups, and they showed us there was no statistically significant differences in survival after living donor liver transplantation among drug-induced acute liver failure and other etiologies of acute liver failure and patients with cirrhosis or hepatocellular carcinoma. So what about Turkey? And in Turkey, this study was published in 2014, and there were 300 patients with acute liver failure, and 2/3 of the patients were adult, and spontaneous recovery was only 36%, and survival of transplanted group was reported at 65. So the etiology you can see in both of the groups, in pediatric and adult, the viral causes are the primary leading factor, and then DILI and mushroom intoxication are the main factors for acute liver failure in Turkey. And recently, TASL Special Interest Group, Acute Liver Failure and Liver Transplantation Group has collected the data from 14 transplant centers about acute liver failure between 2002 and 2019. And I would like to thank for Professor İlker Turan and Mr. Karasu for their job and their contribution. I hope they will publish that data in a very soon in a good journal, and I will show these results on now. There were nearly 7,000 liver transplantation between 2002 and 2019 from 14 tertiary centers. And living donor liver transplantation was performed in, there were 336 patients were performed in, for acute liver failure, about 5%, and 2/3 of the patients were adult, about 100 patients were pediatric, and living donor liver transplantation was performed in 221 patients, whereas deceased donor liver transplantation was performed in 115. The majority of patients had massive necrosis in explanted liver, and no donor death was observed in living donor liver transplantation group. And the mean pre-transplant MAD score was 31, and the PAT score was 27, and 73% of the patients had grade 3 for encephalopathy, and the median waiting time until liver transplantation was 4 days. And the most contributing etiology of acute liver failure in adults included viral hepatitis, and indeterminate group, and DILI, and 2/3 of the DILI group were mushroom poisoning, and in the children the most common etiologies were indeterminate group, and then DILI and viral hepatitis, and 24 different agents alone or in combination along with unknown drugs or herbal remedies were thought to cause DILI-related acute liver failure in total cohorts. And you can see the etiology of DILI-related acute liver failure, and among the most common were mushroom poisoning, and then acetaminophen about 8%, antituberculous drugs about 6%, and ornithazole 5%. Yesterday, Professor Turan presented this case series, and amoxicillin clavulanic acid about 5%. The time until liver transplantation is about 4 days, and the transplant time overall about 65% from living donor, and a little high in pediatric group, about 86% were living donor liver transplantation, and over than 70% of the patients had grade 3 and 4 coma. And 1, 5, and 10-year survival was about 70% and 68% and 68% for 10 years respectively. And the dominant cause of death was infections after transplantation, and 3 patients were retransplanted because of the graft dysfunction, early graft dysfunction, and those are retransplanted, but those 3 patients died after the second transplantation because of the sepsis and multi-organ failure. And you can see the post-transplant survival in patients with acute liver failure, and the worst survival was seen for vascular group, and on the other hand, there was no difference between viral, DILI, or undetermined or other causes of acute liver failure. So interestingly, the living donor liver transplantation was significantly has better survival in adult patients according to the deceased donor liver transplantation, but it did not differ for pediatrics, and 1, 5, and 10-year survival is about 78, 75, and 74 for living donor liver transplantation. On the other hand, in deceased donor liver transplantation is reported as 60, 53, and 50 for deceased donor liver transplantation. And interestingly, there was a remarkable difference between non-mushroom related acute liver failure and mushroom intoxication. The patient with mushroom poisoning had worse survival than other groups, and the precise mechanism, we cannot explain the precise mechanism, but it may arise from timing of transplantation or the type of transplantation, because all the family members Gökhan mentioned about it might eat the mushroom and living donation. That's why living donation became impossible in those groups, and so liver transplantation can be done only from cadaveric donation, and in our country the cadaveric donation is very limited. So when we look at the predictors of 6-month mortality after liver transplantation, age, pre-transplant high MAD or PAD score, the grade of coma, transplant time, the presence of massive necrosis in explanted liver, and high serum sodium and high serum creatinine and high arterial lactate level were associated with 6-month mortality, and there was no significant difference according to sex, BMI, etiology, and bilirubin and INR and ammonia levels. And on multivariate analysis, age, pre-transplant MAD or PAD score, and the grade of coma, and transplant type from deceased donor transplantation, and massive necrosis, the presence of massive necrosis in explanted liver, and high serum sodium level and lactate level remain significant for prediction 6-month mortality after liver transplantation. So in summary, drug-induced liver injury combining both paracetamol and idiosyncratic accounts for more than 50% of all cases of acute liver failure in the USA and in Europe. On the other hand, paracetamol is not an emerging reason for acute liver failure in Turkey, and viral cause and DLA are the primary leading factors for in our country. And with the development of liver transplantation, the mortality rate in those patients with acute liver failure has dropped significantly. And living donor liver transplantation may reduce waiting time for patients with acute liver failure, and living donor liver transplantation may have better survival than deceased donor liver transplantation in selected patients. And thank you very much.
Thanks very much, Dr. Akildiz. A lovely talk. Your Turkish data is really interesting, and I'm sure there'll be questions. Can I encourage the audience to submit questions? We will try and ask as many as we can to our speakers. Otherwise, I'm going to give them a hard time. But they've been great talks so far, and I'm sure that my colleague from Nottingham, Professor Aital, who's going to talk next on the future for drug-induced liver injury, is going to give us a very thought-provoking talk on where we go next and what needs to be resolved. Guru.
Can you see my slides now?
Yes, Guru, thank you. That's great. I think you're good to go.
Okay. Hi, thank you very much for staying back, those of you who have stayed back. I'm trying to conclude it by the questions which I thought went unanswered before, and I've added or modified it. Till I came on to this session, I've been listening and adding my slides or modifying my slides so that I did learn a lot of what we know or what I didn't know, but what new. And now I know what I really don't know. So my talk will be focused on the questions. So we'll start with how do we improve recognition of DILI? What we need, one of the talks came up on artificial intelligence, and we will find a way. So what we need for proper evaluation of risk benefits between the drugs, which we don't know, because most of the DILI and most of what you have heard today all have come from cohort studies, observational studies, and they're not really systematic. What is missing in most of the studies is that how many people received these drugs. So prescription event monitoring is one of the methods of really assessing risk of the drug. Then you can decide whether the benefit is worth it, but they are very rarely done. This is one of the examples of that, which is done by my colleague and friend Ayako Suzuki in America. She hasn't published it, but she has allowed me to present this data. She did a presentation in EASL annual meeting about 3 years ago, but she's still refining the algorithm. So this comes from a VA data. Okay, you can see that people exposed to carmoxyclav, there are 1.8 million people. And you develop an algorithm based on how do you detect bona fide drug-induced liver injury. I'm not going to go through the different steps, but gives you the principles of how it comes to. So she took away people who had raised liver enzymes previously, then took away some codes which might be conflicted diagnosis, then came up with about 800,000 people who she thought were suitable for further analysis, then develop an algorithm of identify a signal which you can put a threshold for within their database, within the period which is seen as a high-risk period, and then look for outcomes as well as exclusions. And then she came up with a figure of almost 1% of people with carmoxyclav develop drug-induced liver injury in a solid definition, which we follow now, not any raised liver enzymes. I heard Adrian telling that the first few years of their database, there was none for carmoxyclav, and then suddenly they cropped up. And I remember Bob Fontana talking to me about 2010, 2011 in one of the ASLD meetings saying, well, it doesn't cause any death. And then you go to liver tox and then grade the drugs into their potential toxicity and re-challenge rates. There were a huge number of them. It comes as a class A drug. So this is the truth. So 1% of people with carmoxyclav exposure seem to have drug-induced liver injury. And this is with the caveat of what this kind of studies do have, but it's still useful addition to all the cohort studies that we do. And those who get DILI, 1.29% end up with liver-related death or a liver transplantation, and another 12% die. And this is an outcome of event of DILI because many of them have comorbidity and their mortality is much worse. So this is not surprising if you look at the DILI group database on non-liver related deaths which follow drug-induced liver injury. And then you get a risk factors with an odds ratio, which is pretty tight because it's a large database. And you tell you the ethnic susceptibility. Some are protected, some are really more predisposed. So this kind of data then is necessary primarily to develop any kind of machine learning algorithms for you to automate detection of drug-induced liver injury. And if you can do it for another antibiotic that comes up, which might have a DILI signal, then you can say, well, do we have something competing which is much better profile or this? And this is a constant question which the regulatory authorities ask for drugs where it is not a novel indication. This is not an orphan condition, but still might have a benefit in introducing, but then you need to do a risk-benefit ratio. At the moment, it is all time-bound. You got in drugs which are more toxic 30 years ago, they're never replaced, but your new drugs are really taken off or never really get a licensing if they've got 1 in 10,000 mortality or a transplantation risk. And that is the last few drugs which have come off the market or withdrawn from the drug development. Clinical practice. What you need to do is consider DILI. Rest of the time, we know how to really work it out. So this is a very interesting study with Thierry Poinard did a few years ago. So he went through his hospital-based database to find out how many DILI were recognized and diagnosed over a period of time. My recollection is that it was about 6 months. And that is what he called a standard strategy. And then for a week, he allocated a team, a biochemist, to look for signals of liver injury. He took a lower threshold. So you might argue that it exaggerates the difference a little bit. Still, then every patient who has this signal, a hepatologist, biochemist, and a pharmacologist go to the ward, see the patient. These are all purely inpatients and say, well, is it drug-related, not drug-related? And his finding was that 12-fold increase in drug-related event identified compared to standard regimen. So which means that you need to consider it in a systematic way for you to diagnose. So this is coming to about how do you improve the recognition of the drug in a broad sense, as well as risk assessment of individual drugs, as well as in a clinical practice. And confirming the diagnosis, Marsha raised a question about RuCam. She gave a very good talk on RuCam, and SIOMS actually hosted this conference, and it was organized by RuCam, Russell Eckloff company at the time, industry, so that's why it became a RuCam. Now, with American colleagues and European colleagues, me included, we have been trying to improve the historical RuCam, which has been there since 1990s. And this is now called ReCam, not because we have revised it, but it's a revised electronic causality assessment methods. This was presented last year in ASLD, and publication, the draft is ready, and this will be available electronically in LiverTox database and elsewhere. So what we have gone through is 2 big registries. Again, coming back to the point that Marsha was saying, well, it's good that we have got very good quality registry. And we developed the domains and modified the domains. Top 4 domains remain in the new format: latency, washout time, competing diagnosis, and previous report, and refined them. So these time period, another question came up during the discussion saying, well, are we cutting off the drugs too early, looking at only the first 3 months period? Probably. And we have gone through a real DILI cases and their distribution of time period, of latency, and then modified the scores based on that. In the same way, competing diagnosis, refined diagnostic tests have come up. So we are giving scores as to how well these things have been excluded. And we have now designed this RUCAM, and just the graphs will show you in 2 databases. Top one, I think, is from the DILIN, which is America, and the bottom one is Europe, which is from Spanish registry, how the scores vary in a graded way, almost as a performance characteristic of causality assessment method, to improve their access as well as their accuracy or helpfulness. I wouldn't say accuracy, helpfulness to clinicians. So again, it doesn't mean that every case is obvious you need to check, but if you need it, this will be available probably in about 18 months' time. The next question, that can we preempt and prevent DILI? This is the, I would say, what people call a holy grail of drug-induced liver injury. Why do we see drug-induced liver injury? Because we don't pick it up during drug development. In the preclinical phase, there are no animal models. There won't be animal models because the 2-3 animal models that have come up really identify probably a way, add to our understanding of mechanism of DILI, but don't really can be applied to all the drugs that we have or that come up. And during the clinical phase of drug development, the RCTs are too small. I just told you that there are plenty of examples where 1 in 10,000 outcome as a death or a transplantation, drug has been withdrawn. Just doing a simple stats, you need 30,000 patients to be exposed for a reasonable period of time, let's say 1 year, for you to really find that signal and probably signal as a statistically significant. So it is so prohibitive that drug development will not really be changed in that way. So is there any way we can prevent DILI in clinical practice by prescribing for a low-risk individuals? And can it be helpful for drug development? So I just presented my 1 slide of fluclox-induced drug-induced liver injury, and this is the cohort I have used, but this is not standard Manhattan plot of genome-wide association study. There you show SNP as a dot, and you have a log p-value on the y-axis. This one is actually epistaxis. Epistaxis is where one variant in a gene and its influence is dependent upon presence or absence of another variant. So it's a pair. Each dot is a pair of genes where each other influencing them. So I took, with the help of a mathematician called Oliver Delrieux, he's a French mathematician, also a neurologist, who did this for me. And this picked up the top about 2,750 SNPs and looked at the epistaxis phenomenon, and it got some signals, 926 distinct genes and 48 outside MHC. As you know, I spoke about yesterday, mostly HLA-related associations. Our idea was that, is there something outside HLA-related genes? And this is a network analysis of that finding from the Manhattan plot, which shows you, let's say, entry point is our DDR1, which is a chromosome 6 gene related to HLA. It's involved in T-cell activation and participates in recruitment of leukocytes in liver injury via cell-cell interactions. And if you look at the kind of genes or SNPs that are coming up, they are involved in immune response. There are genes which have regulation in lipid in the liver, lipid metabolism in the liver, and substantial number, which are in coded blue, which are related to leukocyte trafficking, cell adhesion. And just to highlight one of these here, called GB1, let me see, I can find a highlighter. You can see here, GB1, which is a gap junction related protein, which is influenced by gene, which has been shown in animal models to be predisposing factor or a key factor in determining degree and propagation of paracetamol overdose related liver injury, for which there is an animal model. Moving on, this last year, 2018, there was a paper on what's called a polygenic score. This is a concept of how can we utilize the knowledge that we have got in series of genome-wide association studies to identify a score which is automated, which picks up people with common condition but at risk, so that you can time their preventative measures early enough to make a big difference, their outcome. I've just put in all the 5 conditions they included in that. This is just to show you the principle of it, which is coronary artery disease, atrial fibrillation, type 2 diabetes, inflammatory bowel disease, and breast cancer. Okay, so the second column, he's got what kind of population they use to develop this score, what they call a polygenic score, and then replicate it. So it's like 3,963 cases and 120,000 controls. And that is kind of in a validation data set, and then this is in the derivation. Fourth column is the derivation. So big databases, okay? And SNPs were picked up from already existing the GWASs that are published. And if you pick up almost 6 million SNPs, automate it, and you get a test with a receiver operator characteristic area under the curve of 0.81 for coronary artery disease. And it will pick up about 3.4%. This is in the column 3 in the population who are almost like 20-fold at risk to get coronary artery disease, well ahead in advance. So the same way, they have come up with a way of prioritizing population into groups or a tool which can pick up those groups where preventative measures can be introduced. Okay, 3% to 4% doesn't look like big, but I can tell you that NICE provided a guidance for a cancer screening about 3 years ago. They were looking at positive predictive value of 2% for them to be going through the pathway. So this is not really extraordinarily unusual. So this is a polygenic score for common conditions. Now, what situation that might be possible where people already have their sequences available for a fed to the computer or a program where it will create an alarm saying, well, okay, based on this database, this polygenic score, these are the risk factors we will highlight. And this is, again, not unusual. For some of us might know that 2012, I think, the annual report of our then chief medical officer is called Generation Genome. And there is one chapter on pharmacogenetics and how it can be used in population health and public health. And this is some company, or not company, these are really health providers. I think insurance company maybe, Adrian might enlighten me on it. And they have got a program called MyCode. And you can consent at the time you are registering with this program, and there are already 190,000 people who have allowed their DNA to be scanned and their sequence to be stored for future research at the moment. And when the indications come up, you can really use these kind of databases to find out what their risk score is. So it's nothing extraordinary or out of ordinary. All you need is, you might know about 100K project in UK, which is actually sequencing people at the moment prioritized with what they call cancers or rare diseases. There is a big list of who can really get into this program in UK. Coming back to polygenic score, this is a publication I'm a co-author of, which was led mainly by a guy called Taka Takanubi, who works 60% of the time in US and rest of the time in Japan. and it's published in Nature Medicine last year. So we have done GWASs. I presented many of them, yes, some of them yesterday, and we have got enough data about drug-induced liver injury. And this was a drug which was under development called Fasiglyfam. This is a new generation potential anti-diabetic drug. It's a free fatty acid receptor agonist. There is nothing like that before. And during development, they found that it had DILI. So they had stored the samples of, they picked up 43 DILI patients and 129 people who are exposed to the drug, but who did not get DILI, and then did a genome-wide association study. And I don't want to show you the Manhattan plot. They got some signals, not really very, very high, but what they did was really, how can we use this to identify a group who are susceptible for DILI in general before they can get it? That's a concept of polygenic score, as well as can we pick these signals up using these kind of scores in vitro studies. Okay, so I'll show you very bare number of data so that you can see the potential of this. They used our GWASs, hence we needed to help them how to analyze it. But just one graph on the right-hand side you can see, and this is on the x-axis is polygenic score that is derived from our GWAS, which was showing some signals on cholestatic or mixed drug-induced liver injury. I showed the data yesterday, and they didn't really take up just the p-value of significance which we published. They took a threshold of all signals, because this is about really enriching all the minor signals. So it's almost like a principle of where you take the effect size and a p-value together and use, there are statistical principles used in game theory, and you develop a score like that. And then in the y-axis is an expanded variance of DILI due to Fasiglyfam again. And you can see the signal, highly significant signal, which means that Fasiglyfam DILI is genetically linked to a cholestatic and mixed DILI due to many other drugs. So this is a new drug, which is first in kind. We don't know, we didn't know the mechanism of it, and none of those kind of drugs would have been included in our GWAS, but it tells you that these signals are generic, and they're not always coming up as significant, because GWAS is definitely and deliberately designed to take away any false positive signals. So what we report in the publication is just absolutely robustly true positive signals, and it ignores a lot of signals which can be used for this. What did they do then on? So this they took donors, okay, and donors who were they bought it actually on the internet, primary hepatocytes from donors, and then also got some inducible pluripotent stem cells and converted them into hepatocyte-like organoids. And then they tested in vitro testing of known hepatotoxic drugs, multiple ones. I've shown you a panel, one panel of that here, 1, 2, 3, 4, 6, 12 drugs are there. And then just did the polygenic score to the cell culture, which tells you about individual donors' profile of genetics, and saw whether the viability or toxicity. So you can see x-axis is polygenic score, y-axis is viability. So there is a correlation between the polygenic score that is derived from our cohorts, nothing to do with this particular drug we are talking about. And these drugs they are challenging are again unrelated, cyclosporin A, ketoconazole, troglitazone, toclafone, acetaminophen. So these kind of drugs are now showing a signal there. So then they developed network analysis, and I didn't really show you the proteomics results and transcriptomics results. So they demonstrated that transcriptomic profile of these cells generate potential mechanisms which can be picked up through the genetic polymorphism. So you link the genetics to the potential mechanistic pathway, and then that to the cell viability assay, which demonstrate toxicity. And this is like a final conclusion diagram. This is a putative mechanisms, which are pink ones are derived from polygenic score. So these are the polygenic scores are hinting towards as a genetic potentials. I'll tell you about what additional learning you can do from it, but I'll move on to my next point. So what are the next generation biomarkers? So you prevent it, and then when it happens, we don't have a specific test. You heard brilliant presentation from James Deere, and I will just talk about one study, one slide of TransBioline, which is an IMI program, which is really trying to test some of the biomarkers. But I wouldn't be going too long in detail. This is the paper which was published from previous IMI program, which is a collaboration between European and American researchers, which highlighted a prognostic biomarkers, or you can say safety biomarker. We all use MELD as a test, and they used panel of 11 biomarkers, and then eventually this is the best they could do. If your MELD is more than 30, there's a significant risk that one will end up with death or a transplantation. If it's less than 20, there is very low risk of that happening. There is a score intermediate where it's very difficult to really distinguish, and they use two biomarkers in that. One is cytokeratin 18, you heard from James about. Another one is macrophage colony stimulating factor receptor. So there are specific cutoffs, and they will help you to stratify these. And we are trying to look at these biomarkers in a big cohort of cases and controls to see whether we can replicate it. That's not the only thing we are doing, but that's all I'm going to talk about. And the next one is microRNA profile. It also comes from Dillon group at the time. So they looked at microRNA profile, and we are looking at it in a next generation sequencing. So we will have a panel of microRNA to see whether they can distinguish people with DILI versus alternative diagnosis, as well as whether they tell you about who does better and worse. And this study had about 11 microRNAs, different kinds. The panel title is below the diagram here. And 3 of them went down during DILI, others went up. Eventually, it isn't a robust study, but hint was that if you take a cutoff of microRNA, it gives you very good sensitivity predicting 100% survival, which means that you don't need to worry about referral to a transplantation or not. But again, this has not been validated. And again, it's in a small sample size. You can see that there were just 11 people who met the endpoint. Just one point, which I'm not going to talk about, is that future drugs. Are these suitable for future drugs? A lot of drugs are now immune mechanism targeted. Biologicals are, checkpoint inhibitor-induced liver injuries are, and so we probably need to look at cells. Again, without wanting to repeat it, you had 2 talks where you highlighted yesterday, and there was a presentation this lunchtime, which all talking about how we can identify cells circulating or in the liver, which might become a biomarkers for drug-induced liver injury. So it doesn't have to be protein or genetic. Finally, can we deliver clinical trials in DILI? You had an ALF consortium, you heard from Adrian, and they still shied away from doing a DILI study because it needs international collaboration. So I'll tell you about one of the studies which we are doing. Again, came up as a topic that anti-TB drug-induced liver injury. You saw 2 studies which had done a re-challenge of drugs. Both are very small sample size. One of them said all 3 arms are equal. Another one suggested that maybe giving rifampicin and not rifampicin, pyrazinamide might be the key problem. So we have now HTA funding. We are meant to start last year, but we are going to start as soon as the COVID is finished, probably May this year. And it will be a 6-year study. We aim to enroll about 5,000 patients with TB in UK. We will start them all on a standard ATT, and we are looking for DILI occurrence of 7%. When they resolve, we're going to re-challenge them with or without pyrazinamide, and we hope to really find an answer, because this is what is globally needed. And the point about this is that you need really collaboration internationally. As a link to the study, we hopefully will do, this is a dream of pharmacogenetics, where you both link genetic susceptibility to efficacy as well as adverse effect. This is a study done in Japan, I think, where they did a genotyping for NAT2 before patients were treated with anti-TB drugs. And the genotyping was delivered. There was a question yesterday saying, well, how quickly you can give the results. They delivered for all the people who are enrolled in 72 hours genotyping. They gave it to a center where they decided, they randomized them into pharmacogenetics-based treatment. So the dose of INH was decided based on acetylated type in one group, and the standard treatment was given in another group. That was it. That was all they did. And in the group which was pharmacogenetics-based, event of DILI as well as treatment failure was small, which means that efficacy was better, drug-induced liver injury was smaller. And that is probably the aim for drug-induced liver injury. I thank again for collaborators without which you can't do any research in this kind of study. And if Turkish Association for Study of the Liver want to join it, we welcome them with warm heart and open arms. Thank you very much. These are my funders.
Thank you, Dr. Aital. Information and happiness increases if you share them.
Oh, oh, information, you mean?
Information and happiness.
Yeah. Okay.
I hope the collaboration between TASL and BASL will produce fruitful results in the future and more collaborative studies.
I hope so.
We have many questions, mostly to Gökhan related to mushroom poisoning.
Sure.
Although we are ahead of time, I pick a few of them and I'll ask. First question from Ramazan. He asks if you recommend to continue the liver assist device or plasmapheresis after transplantation in order to prevent mushroom-related adverse effects in graft liver and also in other organs.
This is a very nice but difficult to answer question because there is no data obviously on this. But mechanistically speaking or thinking, I think when we replace the liver, this should overcome the situation because this is what happens to the kidney when you do the liver transplant. The kidney injury turns back to normal. The kidney functions. So maybe a renal replacement therapy or hemodialysis, depending on the patient's need, may be a necessity, but I don't think that's plasmapheresis or other assist devices are necessary.
Actually, half-life of mushroom toxins is not so long, but it's not clear the enterohepatic circulation after the transplantation. The amount of toxins in the enterohepatic circulation is not well described yet.
Yeah.
Another question from Müjdat. Do you think lactate levels can be important and included into the transplant criteria?
Yes, according to the North American multi-center study, in a very large cohort of mushroom toxicity patients, incorporation of the high lactate level to the patient's management gives some prognostic information. If their lactate level is high, then they are most probably ALF, and they around 50% of them requires liver transplantation. But if the lactate is low, most commonly they are acute liver injury, and around 80% of them resolves only by supportive measures. Around 10% of them gets transplant, and in that specific study, only one that is seen in the acute liver injury group with low lactate level. Similar results is seen in Malatya study from Turkey as well. So we should keep an eye on the lactate levels in the patients.
If the subject is lactate, there are two phases. One phase is related to liver failure, that liver fails to clear the lactate. On the other phase, lactate is produced because of peripheric circulation failure, hypoxemias, septic situations that makes the clinical situation worse for the patients. And the reason for elevation of lactate may cause some confusion in some patients. In this issue, may I ask to Dr. Rubin about effects of lactate?
Well, clearly, high lactate levels are a bad risk factor for acute liver failure and indicate transplantation. There's no algorithm that incorporates it. In a sense, you can't make a calculation, but it's clearly a risk factor, such as low phosphate as well. But these are all variables that you observe, but we don't have, would be nice to have an algorithm that we could incorporate the various variables into and come up with an idea of outcomes so that you know, one could make a decision about early listing for transplantation. You have to wait till an organ becomes available. But the simple answer to your question is yes.
So on that note, Adrian, I have a question for you about timing of listing for transplantation in particularly the more subacute presentations of acute liver failure, DILI or otherwise. You talked about using NAC in early grade encephalopathy. In the UK, the onset of encephalopathy, in particularly that more subacute presentation of acute liver failure, is one of the criteria that come into our sort of listing thinking. Do you think we should be trying NAC before we list?
I'm not impressed with the benefit. Is my speaker? Yeah, I'm not impressed with the benefit of NAC in non-acetaminophen cases. The two studies, the first one was the one published by Will Lee a few years ago in Gastroenterology. And there were two problems, three really. One, it took ages to recruit enough patients for the study. And for my cynical thinking, when that happens, it means that there's something wrong with the protocol. If you cannot get patients enrolled, you say to yourself, is this really a protocol that represents what we see in practice? Number one. Number two, the primary endpoints were not met. In other words, the outcomes were just not met at all. And therefore, in the multivariate analysis, what came out was that if there was hepatic encephalopathy grade 1 and 2, and that's a very difficult variable because it's very subjective. And similarly, as I mentioned in the talk, you have to be very careful with the grade of encephalopathy, or encephalopathy, as I'm now learning to say. In fact, on my slides, I had to go through all of them and take out all the American words, and I missed a few. And I had to spend time converting all the milligrams to micromoles. I hope you know how much effort I put in here. At any rate, the problem of encephalopathy is when a patient is deeply unconscious, it's easy. When the patient is wide awake and is a little goofy, it's easy. But 2 and 3, are difficult to assess. There's no objective measure. So that's the second point that I'm a member of the group. That's the second point. And the third point is that when this trial was repeated in children, it completely showed no benefit. Yeah. Now, I noticed in Murat's, it was in Kochen's talk about anaphylactic reactions to N-acetylcysteine. I've never seen that, actually, and I've used tons of it. There were days, actually, I have to tell you anecdotally, in America when you could not get intravenous formula of NAC. And we took the respiratory NAC that they use on ventilators for, I forget what they do, anyway, and we autoclaved it. And we would get some reactions because it was not recommended. But I have used, gallons of NAC, and I've never seen a real problem.
I've never seen anaphylaxis. I have seen anaphylactoid type reactions, which they can be managed.
I considered NAC to be extremely safe, and therefore it's not it doesn't fit in with my personal idea of evidence-based treatment. But I therefore would use NAC in mild encephalopathy, because I don't think it's likely to cause harm.
But you wouldn't delay listing. I think that was my concern, that people might think that was a possibility.
No. I think the chances of a benefit that in the long run will prevent transplantation. Remember, even in that NAC trial, there was no difference in outcome, you see, in the primary endpoint, which was, death and so on.
Yeah.
So therefore, I would start it. And if by some miracle, as it were, patient suddenly improved and the surgeon calls you and says, I have a liver, shall I pass it up? That's when you have the dilemma. But that doesn't happen that often. So I would say use it. If the patient gets better, then it's the divine intervention. And it's not going to harm, and it won't have any carryover. There are some side effects of NAC in terms of coagulation and so on, as you know. Okay. But they're mild, and I would just say use the NAC. If the liver comes up, take it.
Okay, thank you. I have 2 questions, both related to recurrent disease. So these are directed for Gökhan and Murat, probably. And then I'll hand back to you, Zeki, if that's all right. So one is there any experience of recurrent mushroom poisoning after liver transplantation in the literature? And then the second question related to recurrent disease or new disease is there a propensity of developing de novo autoimmune hepatitis in the transplanted liver after transplantation for any kind of DILI? So Gökhan and Murat, over to you, those questions.
Yeah, Dr. Jones. Now, if the consideration here is the remaining toxins in the enterohepatic circulation that causes damage in the transplanted liver, yes, this is a possibility, but I am not aware of any data published about the recurrence of the mushroom poisoning in the cases.
Thank you. What about autoimmune hepatitis type features after transplantation? Anybody on the panel like to comment on that? Murat, it's directed for you, but
yeah, we do not have about any data from this issue, but I don't know, maybe Professor Zeki Karasu, he is more experienced than me, but about the the other issue, mushroom intoxication and drug-induced liver disease, maybe post-operative period after the transplantation, maybe we can prolong the plasmapheresis for to prevent the intoxication of new liver, maybe 1 or 2 days. We should. It's not evidence-based recommendation, but I think because when I was a fellow, Professor Zeki Karasu knows there was a patient with mushroom intoxication after the new liver. After 1 week later, again she had acute liver failure, and the explanted liver again mimicking the acute liver failure.
This was the only case that we couldn't explain the reason. Really, the transplanted liver had similar histological characteristics that explanted liver showing, and the patient died 1 week later with acute liver failure again, and we couldn't explain that. For the question regarding if there is a tendency for autoimmune hepatitis, I think there is no data about that. I don't know other panelists have any idea about it.
And I don't know, is it the question that whether DILI is recurring, or is it the question that particularly related to mushroom? Why, if knowing the mechanism, why would you think it is a possibility? With the DILI, there was one study, largest longitudinal study comes from Aina Johnson, I think maybe 2012 Journal of Hepatology, where he followed up about 700 people with DILI-related jaundice and looked through the database to see what happened to them. In over a period, I think median follow-up was 11 or 13 years. He had 3.5% developed liver-related outcomes, including cirrhosis, decompensation, and of that, 20% had autoimmune hepatitis, bona fide. So it is possible that, and these 5% of the total and 20% of the total people who got it, it will come to maybe about 1% or so of people with DILI. And you need to keep in mind that it happened within the 18 months period. It could be that the first episode might be misdiagnosis of DILI. It might be autoimmune hepatitis leading on to jaundice, but they were not treated and it recurred in 18 months' time. So that is the best data I have got about autoimmune hepatitis coming back after people having DILI episode, but not all of them got into acute failure.
De novo autoimmune hepatitis after liver transplantation is a known issue. Up to 5% in some studies it's described that 1%, 2% in any subgroup, we cannot say there is a tendency. And Dr. Galip Ersöz again asks about if we apply a nasobiliary drainage that could help enterohepatic circulation. The prolonged effect of mushroom toxins could be prevented. Is it possible? He asks.
Yeah, this is yes. There is some. There is very small data on this, but there is data about percutaneous external drainage or nasobiliary drainage, and we somehow, if block the enterohepatic circulation with these medications or biliary approaches, it may make sense, but it is hard to use in this delicate patient group. So I don't personally prefer using nasobiliary drainage in these patients.
Last question from Serkan Duman. How long should patients with mushroom poisoning should be followed in primary care centers?
This is a very important question, because if we are late to proceed for transplantation, it could affect the mortality in the patients. But we know that most of the cases somehow recovers either spontaneously or by our treatment approaches. So if the INR starts to increase more than 1.5, if the ALT surge is too rapid, as in a study, as I've told you, the AST more than 4,000, or the other coagulation parameters become abnormal, patient becomes encephalopathic, we should refer the patient to the transplant center.
I think we should always remember that if the mushroom poisoning patient with acute liver failure it progresses very quickly, very fast, and it should be followed in a center that transplant is possible. If there is any progression, laboratory or clinical, a patient should be referred to transplant center.
Safer.
Do we have time for one more question, do you think? I think we can go for it. I work in a transplant center, and we're a small volume live donor center, and we have worked up adult donors for pediatric transplantation very quickly, but not adult to adult. How long do you think you need to work up a live donor adequately in the acute liver failure setting when time is short?
And it depends on the family and your center. We can prepare about 6 or 8 hours if the family members are voluntary, and from mother to child there is no problem, but from the adult to adult there was some psychological press. That's why it's more debate in adult to adult patients, but in most of the centers in Turkey able to prepare about 6 or 8 hours, and Gökhan and I worked in private centers and high volume centers. In those centers, you can prepare the donors in the presence of acute liver failure very quickly.
And do you think, I noticed that the outcomes for transplantation in DILI-induced ALF in Turkey are very much better than the international reported data. Do you think that's because you do mostly live donor transplantation and you have to wait longer for deceased donors?
In our country, the cadaveric donation is very limited in daily clinical practice. In our country, about 80% of the patients from living donors. So the living donors have some advantages because you can decide the timing, and when you decide to transplant, the donor is prepared, and then you can go on. But when you decide to transplant, if no living donor, you cannot do anything. And after about 5 years ago, we published a data. There was a correlation between the waiting time and prognosis of acute liver failure transplant recipients, and more than 6 days had worse outcomes. So the timing is important in our series.
Yeah.
I can explain only for that reason. So maybe Gökhan wants to sum.
Yeah, of course, it's very hard to manage the multi-organ deficiency and systemic inflammatory response related with the ALF with supportive measures. So the best option is to do the transplant anyway. So we have recently published this as well, and if we like in a country like Turkey with disease donor transplantation is very low, we can ask the family for a donor with a more strong fashion. They can be more willing to donate their organs because they know that psychologically their patients will die because there will be practically almost no chance of having a cadaveric donor. So we are fast. We prepare the patient overnight. We do the transplant the next day. So we don't need to have renal replacement therapy, apheresis, other medications causing more cumulative toxicity. So it's the prognosis is better with the live donation, which is done in a more rapid fashion.
Thank you.
Because of the intervals between the onset of illness and the death is too short, and the timing of transplantation is very important for the success of the procedure, and it should be performed before the patient's clinical situation becomes irreversible. Then, in that point, a living donor helps a lot.
Could I ask, in Turkey, what is the national obesity rate? Does that enter into donor suitability, or are you skinny over there?
We are becoming fatty very quickly. Now, Turkey,
I think around 30%, right?
Yeah, ranking number 6 in the world, Turkey, by means of obesity. 15-20 years ago, actually, none of our donors had problems with obesity, but more than half of them have problems. And donor rejection rate because of obesity increased very much in recent years.
Well, on that note, I think we should move on to the closing remarks from our hosts, and we'll close this session. Thank you to all our speakers.
Thank you.
Thank you to my co-chair.
Thank you. Bye.
Thank you.